All right, hi everyone. So today I'm going to be disseminating my evidence-based practice project on the effectiveness of BPC 157 and PRP injections for management of osteoarthritis. So as we see, many of our patients have osteoarthritis. It's something that we see on a somewhat daily basis. One of the most common causes of osteoarthritis is joint pain and involving in functional impairments in adults. Traditionally, treatments such as corticosteroids often provide temporary relief. However, it does not promote long-term healing. My study is going to compare BPC 157 and PRP injections as a regenerative therapy to evaluate their effectiveness in reducing pain and improving function within my population. So throughout my class, we have had to develop a PCOT question. Basically, my question started off 8 weeks ago as, basically, we had to address our evidence-based research project proposal. My revised PCOT question was defined by clinical relevant to my population. So I started with physically active athletes in the adult population, but then I narrowed it down to just active adults, not athletes. My intervention was also refined from peptide therapy to specifically BPC 157, which is body protection compound. This allows for more targeted review of the existing literature and the clinical application, while PRP remains the comparison treatment throughout the whole study. The outcomes have been significantly improved by incorporating the patient reporting index, which is the Western Ontario McMaster University Arthritis Index, which I will refer to as the WOMAC scale. In addition, this provided a validation and a measurable way to assess its effectiveness. The time frame was shortened from 6 months to 112 to 120 days, which aligns better with the standard clinical trial and enhances the feasibility of outcome tracking. So what are BPC 157 and PRP? So BPC 157 is a synthetic peptide known for its anti-inflammatory and tissue repair properties. PRP, standing for platelet-rich plasma, is an injectable therapy that uses the patient's own blood to stimulate tissue repair. Both have been studied in musculoskeletal medicine, but they do lack studies with direct comparison, which is why my study was brought up. My study aims to understand which treatment yields the best outcomes and that are crucial with the growing demand for non-surgical interventions like physical therapy. So this is a conceptual model that I built using the Rogers diffusion of innovation theory. It's a theory of implementation, so basically how I'm going to implement my study into clinical practice. So this model will assess healthcare providers and stakeholders' adoption of BP 157 in using this theory. So how can BPC 157 be introduced in this clinical practice? There are 5 stages: knowledge, persuasion, decision, implementation, and confirmation. The knowledge stage is just there to spread awareness of BPC 157. Persuasion is built by sharing the outcomes of BPC 157 and the safety comparisons with PRP. The decision stage will evaluate clinical trial results addressing the ethical and regulatory concerns. Implementation will use standardized protocols, training, and outcome tracking. Lastly, the confirmation stage will have the long-term follow-ups, continuation, evaluation, and the potential formal adoption in clinical practice. So the purpose and objectives. So basically, like I said, my purpose of my study is to compare the effectiveness, safety, and cost effectiveness of BPC 157 and PRP for treating osteoarthritis in active adults. My objectives include evaluating the pain reduction using the WOMAC score, measuring functional improvements, tracking safety and side effects, and assessing cost effectiveness. So for my search strategy, I'm just going to discuss the inclusion and the exclusion criteria when I was going through and picking my different sources. I did a 10-source peer-reviewed or peer revision between 2020 and 2025. So my inclusion criteria included studies that focused on osteoarthritis treatment using either BPC or PRP, and using outcomes such as the Lomax pain scale. Exclusion criteria included studies that were unrelated to musculoskeletal conditions and other than adult populations. The biggest one for peptide treatment was like esthetician, like collagen in skin and regeneration there, not specific to musculoskeletal injuries. So for my study, I purposely did not limit the specific body part that osteoarthritis was affecting to broaden my range. However, through just resources, the knees was the probably most studied part of the body that they were looking at. So timeline. My timeline will go, as I said, from 120 to 120 days. This will begin with my pre-implementation phase, beginning with planning and board approval, following by staff training on protocols and data collection. The pilot phase of this study will test feasibility with the injections and monitoring. Full-scale deployment will include enrollment and data collection. And then finally, my final phase will include data analysis and long-term follow-ups, including the assessment of sustained treatment effects. My timeline allows ethical oversight, protocol consistency, and meaningful outcome evaluation. So these are the top 3 sources that I wanted to just go over quickly today that I reviewed. They provided valuable insights, different treatment options. As you can see, we had peptides versus PRP and hyaluronic acid, collagen peptides, and then PRP for tendon injuries. This helped me determine which study I also wanted to use compared to randomized studies, RCTs, and evidence-based summary. I decided to go with the randomized control trial for my study. So although both therapies showed to be valuable and comparable, all studies did provide the same limitation, that there was a caution in variability and the ethical considerations of use. So continuing from my evidence summary slide, both BPC and PRP has its strengths. BPC offers sustained relief and could require fewer injections, such as an oral substitute, but it lacks FDA and NCAA approval, limiting availability to athletes, so not something that we want to offer to our college athletes. PRP is widely used and accepted. However, the price per injection to receive optimal effectiveness can also sway the user. So overall, the evidence indicates that BPC may offer longer lasting relief, but more study and trials are needed. PRP shows benefits in mild to moderate osteoarthritis, but has inconsistent outcomes. And the lack of standardization of PRP and the emerging nature of BPC present challenges and opportunities for more tailored treatment. So practice recommendations. Based on my research, clinicians should continue to use PRP where protocols exist, but consider BPC 157 in instances of research and controlled pilot programs. However, it's important to make sure that you're maintaining the ethical guidelines that must be followed, specifically with BP 157 and athletes. In addition, it's also important to prioritize stakeholder involvement in order to improve dissemination and real-world application. Few more, almost done. So implications for healthcare practice. So both these treatments can improve outcomes, reduce dependency on surgery, and accelerate return to activity. As PTs, you're often the key educators for patients, helping set that realistic expectation and reinforcing the adherence to movement guidelines during recovery. However, this implementation in PT highlights the need for outcome tracking tools such as the WOMAC scale and PROMIS surveys to monitor patient progress. Limitations. So as I mentioned, my study faced a few limitations, including small sample sizes, lack of long-term follow-up, and the reliability and generalizability of results. BPC's unapproved regulatory status presents ethical and clinical barriers to widespread use. While the 112 to 100-day timeline aligns with early trial norms, and it doesn't capture the long-term outcomes essential for managing conditions such as osteoarthritis. These gaps emphasize the need for more extensive randomized control trials, standardized protocols, and cost-effectiveness in studies to inform clinical practice and policy decisions. So in conclusion, both BPC 157 and PRP show promise in maintaining osteoarthritis in adults, offering a non-surgical option to reduce pain and improve function. BPC 157 may provide a more durable improvement over the trial period, but it still remains investigational. Integrating emerging regenerative therapies like BPC and PRP will be grounded through evidence guided by regulatory standards and supported by ongoing evaluation to improve patient outcomes and advance musculoskeletal care. These are my references.